Morning, everybody. I'm Red Schiller, and I'm substituting for Dr. Kalman this morning, who's in Washington at a national conference on community health centers. And I am absolutely delighted to welcome and introduce our speaker, Dr. Veronica Rivera. Veronica is currently an attending physician and preceptor at the Institute for Family Health and at our Harlem site. This is 10 years. So this is not only a presentation, it's a celebration. She's also associate professor in 3 departments at Icahn School of Medicine, the Department of Geriatrics and Palliative Medicine, our Department in Family Medicine and Community Health, and also the Department of Medical Education. In addition, she sees patients at the Family Health Center of Harlem and practices outpatient geriatrics at the Coffee Geriatrics practice at the Mount Sinai Martha Stewart Center for Living, where she currently serves as medical director since 2019. Dr. Rivera received her medical degree from Jefferson Medical College and completed her residency in family medicine at the University of California, San Francisco. She did an additional year as chief resident and then stayed on at UCSF to complete her geriatrics fellowship. Dr. Rivera has dedicated her career to improving the health and well-being of marginalized and oppressed older members of our community and helping them to reside safely in their community for as long as possible. She has focused on improving geriatrics education for primary care providers, especially family medicine trainees, and promoting a diverse physician workforce. She's been honored in the Department of Geriatrics as Clinician of the Year and Educator of the Year for outstanding work. And just on a personal level, I remember our recruiting conversations and just knowing that Dr. Rivera was an absolute gem. And we are so fortunate to have her not only come to our institution, but contribute for so long. So we are delighted to have you, Veronica. So welcome.
Thanks so much, Red. I really appreciate that introduction. I wish I could see all of your faces and see who I'm speaking to, but I really am truly honored, and it's a real privilege to be giving grand rounds to all of you and to have this platform to share what I'm really passionate about and taking care of older adults and in the community. Before I get into the talk, I also want to just take the opportunity to recognize and thank all of you for the amazing work you do at the Institute. I know this work is really hard and challenging, in addition to rewarding, but I know the healthcare system we work in is not perfect and there's a lot of challenges. But I still partner and want to continue to partner with all of you because I really believe in the mission of the Institute and the work that all of you are doing. So like Red said, I celebrated 10 years in October, and I'm really excited to share some reflections in addition to my presentation today. And also if we have time to talk more about future directions, I'm hoping to still be a partner and continue to work with all of you in this really important work. So we're going to be talking about caring for older adults at the Institute, and more specifically talking about a case for the age-friendly health system, which is a framework that some of you may have heard me speak about already, but if not, hopefully this is very informative for you today. One other caveat I want to say is that, we define older adults as those who are Medicare eligible by age, so usually 65 and older. But at the same time, I do want to point out, in which I know all of you are recognizing, that a lot of the concepts and themes I'm going to be talking about today apply to a lot of our younger adults who are having geriatric syndromes, premature aging, due to a lot of the unfortunate health disparities and social determinants of health that we're seeing. So, a lot of what I'm going to be talking about today does apply to your younger patients who have complex chronic medical issues as well. So diving in, my objectives today are to really start by describing the demographic patterns to really set the stage of what I'll be talking about, is sort of what are the patterns of the older adults in the United States and more locally in New York City, and even diving deeper into the IFH, some of the IFH data. Discuss some health disparities trends that we are seeing in the older adult Medicare population, just briefly, and then really use those two things to set the stage for what can we do differently to take care of these older adults, and talk about the 4 M's of the age-friendly health systems and think about how they can be utilized in our FQHC setting. So, and those 4 M's are mind, medications, mobility, and matters most. So in that spirit, I'm going to start on a personal level today with all of you and talk about what matters to me. And so I think for most of you, if I were to ask you what matters to you, you'd probably say family. So for me, absolutely, family is super important to me. I am blessed with a wonderful husband and twin daughters who are about to turn 5. I also have wonderful parents and a brother, and a wonderful extended family, but pictured here are my grandparents. So I joke that pretty much every geriatrician has a grandparent story. And so these are my 4 wonderful grandparents who were very influential in my life. I am half Filipino, half Puerto Rican. And on the left side are my maternal grandparents on my Filipino side. And my maternal grandmother is my actually only living grandparent at this time. And when she immigrated to the US, really helped raise me and my brother, and was a big influential person in my life. And my maternal grandfather, who I only met a few times, he passed at a fairly early age due to a stroke. And then on the right side are my maternal grandparents who lived in Puerto Rico. And I didn't have the opportunity to see as often since I lived in Florida, but were also very important in my life. And I think culturally, both cultures really valued family and elders in our family. And so I think that definitely has influenced me and sort of brought me to geriatrics. And what I really love about taking care of patients and families is knowing more about families and cultures, and getting to know our patients. And so that sort of transitions to professionally what's important to me. And I have opportunities in my role to do administration, education, but absolutely those patient relationships are super important to me. And so I have a picture here. Some of you may have seen this already. This is a sombrero, which was a gift that was given to me by a husband-wife couple that I took care of at Harlem. And I'll tell you this story for a few reasons. So one, the relationships. So the husband was a Puerto Rican gentleman who was in his 80s, used to be a baseball player. He actually still ran in East Harlem 2 miles a day when I knew him, but had a lot of chronic medical issues, severe aortic stenosis, even had a TAVR when I knew him, and chronic kidney disease, along with a few other comorbidities. And his wife, who was younger, Mexican woman, she had a lot of mobility issues, but the two of them were living independently in East Harlem. And so they met on a missionary trip in Mexico a long time ago. And while I was taking care of them, they went to Mexico and brought me back this sombrero, which is still one of my most favorite presents I've ever received. And I tell this story too because it symbolizes those relationships, but also, unfortunately, both of them passed away during the first wave of the pandemic. So they died in April of 2020, within days of each other at Lenox Hill. And I think just sort of highlights how vulnerable and frail our patient population is, the older adults that we care for, and how incredibly important our role is in their healthcare. And so I want to just also acknowledge what's happened during the pandemic and sort of how that's taken a really big toll on our older adults. So that's what matters to me. I also really love teaching all of you and hearing from graduates who are, taking care of older adults, seeing our graduates go into our own faculty positions and continuing to teach geriatrics. So that's really meaningful to me as well. And one of the things I wanted to highlight is that family medicine, primary care, we are going to be doing this work, and we are doing this work, taking care of this older adult population. And yes, we have some geriatricians, but there are not a lot of us. These are some data, some statistics for you. In 2020, there are about 50 million older adults and 8,000 practicing geriatricians, and that demand for geriatricians is just going to increase the more and more our older adults continue to age in our communities. And just another interesting statistic, and this is pretty consistent over the last few years, is we're matching only about 250 family medicine residents and internal medicine residents yearly into geriatrics fellowship for the whole country. So we are not sort of training and recruiting and creating enough geriatricians as we would need. So really a lot of this work is going to land on primary care and family medicine in particular. And a lot of the reason why I still very much value being with all of you and trying to help provide some education when I can. Sort of transitioning to some of the health disparities I wanted to highlight. This came up in a Journal of Geriatrics article just this past year. So I thought it was an interesting paper because we're now talking about not only for older adults dealing with racism, but also ageism. And a lot of our patients are up against a lot to sort of navigate the healthcare system and their own medical conditions. And so I think this was, again, really highlighted with the COVID pandemic, with really increased morbidity, mortality, for consequences to both racism and ageism. And so there's some folks in the community who are really trying to look at this intersection, but I just point out that there's both of these at play for a lot of our patients. Some healthcare disparities in the Medicare population. You know, when I was talking to Red, he asked me about health disparities. And one of my first things I said was, what's wonderful about taking care of older adults is that the majority of them then get access to Medicare, right? So having access to Medicare can really help in terms of access to the health services that we need. I will say with a caveat, this is not everyone. I have a beloved patient at IFH who's 97, undocumented. He has no identification and so can't get legal services, and he lives in a homeless shelter in Washington Heights. So there are patients like him in the system that I wish I knew more about and had more data about. But yes, most of our older adults do end up getting access to Medicare. But there are still disparities. So Medicare beneficiaries of color are more likely to report being in poor health, have higher rates of chronic conditions like diabetes and hypertension, and more likely to use hospital admissions and emergency department visits rather than primary care. And then in terms of secondary insurance, more Black and Hispanic Medicare beneficiaries are likely to have Medicaid as their wraparound coverage. And a larger share of Black and Hispanic white beneficiaries are more likely to be enrolled in Medicare Advantage plans, which is a whole other topic of conversation. Moving forward, also in general, Black and Hispanic beneficiaries are reporting a little more access getting to care needed, even though there are sort of less challenges for this population getting access to care. And then again, the COVID-19 pandemic really highlighting these health disparities with more people of color having disproportionate rates of COVID-19 deaths in this population. So moving on to demographics. I don't have to tell all of you this, you know, our older adult population is growing. Some statistics though, by 2030, we're expecting about 72 million. This was some data from 2013, but really a more racially and ethnically diverse population nationwide, although you'll see in a little bit, we're already seeing that really racially and ethnically diverse population in New York City. And this here shows you by 2060, this is from Kaiser Family Foundation, about 50% of our older adults over 65 will be non-white. So again, these predictions really showing that our older adult population is also increasing in its diversity. Where are our older adults living in this country? California, Florida, and Texas are the top 3 states, probably not surprisingly, but we're number 4, 3.7 million older adults in 2019 in New York State. And then this really drills down to the New York City data. This came out in a report in 2019, so before the pandemic. And I'm going to show you some of my favorite images from this report. In 2019, 13% of our New York City residents were over 65. And you can see the breakdown here, about 7% were over between 65 and 75. And about 2% were 85 or older. So that's a smaller population, but a population that we are seeing. New Yorkers' life expectancy was about 81.2 years, which was a little longer than the national average. And again, the predictions for the growth here continue to stay true. 1.4 million New York older adults are expected by 2040. And then again, the diversity here, even in 2019, only 44% white older adults, and the other populations we're seeing here, Asian, Black, Latino, very well represented. Also super interesting, 49% of our older adults in the city are born outside of the US, which again is going to the diversity that we're seeing in our communities. Non-English speaking homes, again, only 50% speaking English at home, and 66% of older adults reporting they speak English only or very well. Quickly about socioeconomics, 21% of our older adults are living below the federal poverty level. And then 30% of our older adults are living alone, with about 3% of our older adults living in a nursing home. And there is an increase in our older adults themselves being caregivers. So another very important statistic that I share with you here. So let's drill down a little bit to IFH. I am not a data expert. I was playing with Slicer Dicer this week, and I came up with this beautiful graph. So for Harlem here, this is patients over 65 attributed in the last 6 months. Harlem here has about almost 3,000 older adults. Again, if this is accurate, this was from Slicer Dicer. Wonder if this feels right to all of you. 17th Street, about 2,000. Stevenson, about 1,900. And then our colleagues at Walton, Cadman, Amsterdam, Mount Hope, and Urban with smaller numbers here. Sorry, I don't have the Mid-Hudson data, but this is some data from the New York City sites. And then we'll talk a little bit about the Medicare wellness visit, but I show this data because love it or hate it, it does get at the age-friendly health systems and the 4 M's. And so this is data I got from Taylor from January to September, showing the number of annual wellness visits we've completed in this time period in the Manhattan sites and in all of the total IFH sites. Hopefully by the end of this talk, you're going to love the annual wellness visit, but so I just wanted to share some of that with you. So what can we do? Our older adults are growing. We are seeing Medicare beneficiaries at the Institute. What can we do to improve this care? We were fortunate over the last 2 years to get some funding support from the Fan Fox and Leslie Samuels Foundation to do some of this work, which I'll talk a little bit about. But really appreciative of our grant team, Alexis Stack from Care Management, Teresa Engert from Nursing Education, Naomi Bibiano, who's a nurse practitioner in Mid-Hudson, who took over for Dr. Abianca, Lolita, who was also helping out at the beginning of this project. And really what we used to try to make some changes in education, which I'll talk about a little bit, was the age-friendly health systems. And so what is this idea of the age-friendly health systems? And so this was an initiative that came out of the John A. Hartford Foundation and the Institute for Healthcare Improvement that created this framework to describe what is different about caring for older adults. And again, some of this is relevant to some of our younger adult populations who are having geriatric syndromes at earlier ages. But this framework is sort of, again, created for older adults. Matters most, like I alluded to already, knowing what's important to that older adult, what are their goals, their care preferences, and obviously incorporated in that is some end-of-life care decisions. Medications, so we see a lot of comorbidities and polypharmacy in our older adults, so making sure that we are treating those, treating our patients appropriately, and deprescribing when we can. Mobility, knowing a patient's functional status, and knowing and asking about falls and helping to reduce those falls so that patients can live in the community safely. And then lastly, mentation, which is an umbrella that includes both cognitive issues and mood, as two sort of big domains that we see a lot in this population. Just a quick additional slide about another idea that's around is the geriatric 5 M's, which has the 4 M's, but also includes multimorbidity, which is just multiple chronic conditions as well. And thinking about those and how those affect our older adults. So the age-friendly health systems, their key drivers are basically you need to assess your older adult on these 4 M's, and you need to act on them to come up with a care plan and incorporate them into your care. So for example, if you have an older adult, you want to ask what matters to them, document it, and align the care plan with that. For medications, review high-risk medications, do good med reconciliations, deprescribe when possible, dose adjust high-risk medications, and avoid their use when possible. For the mind, screening for cognitive impairment, screening for depression, and then if those are positive, treating those conditions, treating the depression, and for the dementia, further evaluation and management, and I'll talk more about that in a little bit. And then screening for mobility limitations. So making sure patients are safe, have the appropriate equipment they need, the support they need to live safely. Sounds easy, right? Let's talk about a case. So this is a real case that I have at IFH, and I am showing this not to scare you, but also to highlight how complex our patients are and can be, and highlight also all of the M's that are going to be coming up for this patient, and also highlight that because we're in primary care, this is very much work that needs to happen over time. This is all not going to happen at one visit, but because we have ongoing relationships with our patients, we have the opportunity to address some of these issues over time. So this is my lovely patient, Miss Rosa. She's a 90-year-old female, complicated history, diabetes, peripheral artery disease, falls. When I first met her, I went back and reviewed her chart. She had a complicated hospitalization in 2019, where she had respiratory failure, requiring intubation for cardiogenic and septic shock, and an NSTEMI. So she presented to the first time to IFH at Harlem in August of 2020, not with me, another provider. And her first visit, she came in with a fall. She had a fall in the bathroom, had large bruises on her breast, and some pleuritic chest pain. Briefly, she's on Janumet, glipizide, basaglar for her diabetes, cilostazol and clopidogrel, gabapentin, and a rivastigmine patch. She was referred to care management and a shower chair, ordered a shower chair, and her A1C was 7.2, so the provider wonderfully discontinued her glipizide and also discontinued her cilostazol, because at that time wasn't sure what she was on it for. And so I'm going to keep going back to this case, but I'm going to show you a visual of her visits since then and give you a brief highlight, and then we're going to go back into more details. So this first visit in August was the fall I just described. She came back in November. They discontinued her metformin because her GFR was low. She actually she got COVID in February of 21. In July is when I first met her. Unfortunately, her provider left Harlem, and so I met her. After realizing her significant hospitalization, I did address her goals and signed a healthcare proxy. I don't usually do that on the first visit, but I sort of jumped to what matters most here. In September, I really dived in more into her social history, which I'll share later. And then in November, started to look into her cognitive issues. I did confirm her dementia by doing a mini cog, and really started that process to try to get her more home care hours. In February, her and her son were endorsing a lot of apathy and depressed mood, so I started her on sertraline. Her mood actually was getting better, thank goodness. We also decided to try to taper off her rivastigmine, so again, mind and medications here. Also referred her for some home physical therapy and a home safety evaluation. And as you can see here, unfortunately, she continues to fall. And in July, August, December continued to fall over these visits. And this most significant fall in August, she was hospitalized with rib fractures and then sent to subacute rehab. And then had a hospital visit, follow-up visit in between. And again, still trying to increase those home care hours. And December, another fall, she went to the ER and was sent home from that one. I've had a few more visits that I don't have in the timeline here, but I'll reference in a little bit. So thinking about her and those visits over the last 2 years or so, I'm going to talk sort of, again, superficially go into each of the 4 M's and sort of things we should be doing in primary care to assess them and act on them. And as a caveat, I can do pretty much a full hour talk on each of these M's, and I have been doing those for the residents. So this is not, we don't have enough time to get into everything, but I just want to give everyone a broad overview. So dementia, so that first M, cognitive impairment screening for dementia. Just quickly, I always love to remind folks about the prevalence. Our community dwelling older adults who are in their mid-60s, the prevalence is about 5 to 10%. And this doubles every 5 years, with estimates of saying by the time our folks are in their 80s, 90s, about 30 to 50% of this population has dementia. So really important to screen. USPSTF does not have guidelines to advise for screening, but I'll talk more about why that is important. And then, yes, this is a costly condition that is really going to be an increasing burden to our healthcare system. How do we diagnose dementia? The DSM-5 actually changed the nomenclature to major neurocognitive disorder. And just as a reminder, we are looking for evidence of cognitive decline from a prior level in one or more of the following cognitive domains: learning and memory, language, executive function, complex attention, perceptual motor, and social cognition. And this impairment needs to actually affect their function, so their ADLs and their IADLs. And early in the disease, it's really those IADLs that we start to see signs of dementia. And this is not in the setting of delirium and not in the setting of another primary psychiatric illness. So why do we screen? A lot of our patients will not complain of memory loss, and patients with dementia are at high risk for accidents, delirium, medical non-adherence, and disability. And for our non-Hispanic Blacks and Hispanics, we're also seeing delay in diagnosis, and often by the time of diagnosis, having more advanced dementia. My takeaway for you today is the mini-cog is a very effective, quick, easy test that literally takes a minute to do. And I'll show you the results of our patient's mini-cog in a minute. I often teach folks to, once you get an abnormal mini-cog, you can take some time in a future visit to follow it up with the mini mental status exam, although that is proprietary, and the main reason it's not an Epic, and also technically we should be paying for it. But we've been moving a lot in the community to the MOCA, the Montreal Cognitive Assessment, or the St. Louis University Mental Status Exam, or SLUMS, is another excellent validated tool. This is our patient's mini cog. She actually got it done twice. I think I did the first one, and then I had a resident with me who also conducted a mini cog on her. So you can see, obviously, her clock is quite abnormal. I'll get to this in her social history. She only had a few months of education, so that is something to keep in mind. But she worked as a home attendant. She could read and write. So this is quite significantly impaired for her. I use the 3 words ball, flag, tree, penny, dog, orange, apple, table, penny, any 3 words you want to use. Ask them to repeat them, and then you're going to ask them to recall them after you ask them to draw the clock. All the numbers, the time 10 past 11, and that's a simple, easy cognitive screening test. It's built into your annual wellness visit. But again, you don't have to do this in the setting of an AWV. You can do it very quickly at any point. Transitioning to mood, everyone is pretty comfortable with screening for depression, PHQ-9, anxiety, GAD-7, and obviously you want to, our medical assistants are helping us with these screenings, thank goodness. So reviewing those results and assessing and treating when needed. And also in this population, we're seeing a lot of bereavement, social isolation, loneliness is a huge hot topic right now in this population. So really thinking about those as risk factors and thinking about ways to sort of help address those. In our case, again, she presented with apathy and she responded really well to sertraline. And so how do we act on these abnormal screening tests? If the mini cog is normal, like I mentioned, you really want to know that functional status. You want to know, is the cognitive impairment impairing their function, their IADLs? And this may require some collateral information, which I agree is hard to find sometimes, but really important to try to ask and get some other information when possible. And this is a difficult test to interpret, especially if there's a low level of education, there's low literacy levels that we do see often. Also, if you're not doing it in the patient's native language, or if at the time of the testing, their mood is abnormal. So those are things to definitely consider. Also, hearing and vision impairments that we see with our older adults are also things that are challenges. And then again, scheduling a follow-up visit for more evaluation. I'm also happy to be a consult on any of these cases that you're struggling with for patients who have dementia. I think really the mainstay of treatment for me is treating those behavioral disturbances when they come up, hopefully in a non-pharmacologic way. But yes, we do need medications often to treat these behavioral disturbances. And really thinking about that patient and their community, making sure they're safe is always my #1 priority, removing hazards, helping them with their medication management, thinking about blister packages, and making sure they have adequate home care hours is really important to safety. And then another huge piece is the caregiver. Again, we're family docs. We know we can't think of our patients in isolation. Those caregivers who are on the ground day to day, taking care of these older adults, making sure they have appropriate services and support for them, and connecting them to community resources when possible. In New York City, I talk a lot about Caring Kind as a wonderful community-based organization that helps support a lot of our caregivers. In terms of depression, you know this well, depression care management programs, referring to mental health. I wish I had better news for you about geriatric psychiatry resources. They are limited and very rare to find, but partnering with your mental health teams to help manage these patients is incredibly important. There are a few community-based programs that we often refer to here in New York City, the special program for older people, which is based on the Upper West Side, and then Integrity Senior Services. So those are two resources you can look into a little bit more. In terms of mobility, we're talking about screening for function and falls. So I'll explain what I mean about that. So functional assessment is like a geriatrician's vital sign. I 100% prioritize this on every first visit of knowing what is my patient's baseline functional status. I cannot stress enough how much we value, for many reasons, a patient's functional status. Those ADLs, the basic activities of daily living, walking, dressing, transferring, toileting, feeding, grooming, and bathing. Bathing are the most complex of those. So if you have no time at all, at least ask, can you bathe yourself? Because if they can bathe themselves, chances are they can do those others. The instrumental activities of daily living, those are the more complex tasks that we need to get done on a day-to-day basis, using the phone, preparing your meals, finances, medications, laundry, transportation, shopping. And so in my mind, I always think cooking, cleaning, laundry, managing finances, managing meds. Those are really important to ask about. In our case, Miss Rosa, she was dependent on bathing and dressing. She did have incontinence, used pull-ups. She had a hard time mobility-wise getting to the toilet. She would often grab onto the wall when she was walking at home, and did have access to a walker and a wheelchair. And she came to the office visits in a wheelchair. In terms of IADL, she was fully dependent, and I'll talk about family in a little bit. The daughter did her med management, her bills. She did use Access-Ride, even though she was walking distance from the clinic. In terms of function, my other takeaway for you is that this is not a static thing. It is something that does change over time. And so it's important to document it frequently. And in our EPIC, we have beautiful flow sheets that allow you to track function and document it. And that is part of the annual wellness visit as well. But just to show you, patient A, here is a healthy older adult who has no comorbidities. And as this patient ages, will have some gradual functional decline over time. Patient B is someone who has a progressive illness like Parkinson's that precipitates their functional decline a little bit more quickly. And then patient C is someone who has an acute event, could be a massive stroke or other illness that requires a long hospitalization, has a significant precipitous decline, but they can maybe rehab some of their function back, and then over time, a gradual decline occurs. So that's function. Fall screening, there are multiple fall screening tools out there. This is an example one from the CDC. We obviously have some falls questionnaires built into our own EPIC that are part of the annual wellness visit. But some important questions are, do you feel unsteady? Are you worried about falling? And have you had an actual fall? This prior falls is a super high risk for future falls, as is evident in our patient's case. And so for her, she had multiple falls and still continues to have a high fall risk. And a lot of her biggest fall when she fell in July, she was getting up out of bed and she hit her head on the side table. This was before the home attendant came. She luckily was able to grab the phone as well and call for help. And she does have a life alert. She's had other falls in the middle of the night where she got up at 3 a.m. with the urge to urinate, and she fell coming back to her bed. We've put a lot of things into place. She has a bedside commode. She has, again, she has a life alert, but still with those things in place and her dementia, she's just going to continue to be a high fall risk. And so advocating for more home care and support is something that we often try to do, but it's a little bit of a side comment, but I think these falls are really hard to manage, but important to know about, and just thinking creatively about how to reduce those risks. There are screening assessments, the timed up and go, which again is part of the annual wellness visit, standing up from the chair, walking 10 feet, turning around, sitting back down. Less than 10 seconds is normal. My takeaway is always, please just watch your patient walk. Watch them walk into the room, watch them leave the room. It's very easy to not even see your patient move at all, the way a lot of our workflows are set up. So what do we do in terms of abnormal, if your patient has abnormal screening or they're high risk for falls or having falls? I really like to think about all of the risk factors. Is it bad footwear? Is it a poorly used assistive device? Is it medications? Is it the Parkinson's? Is it neuropathy, bad pain? What can we do to reduce those risk factors and treat them as possible? Refer to physical therapy, developing great relationships with therapy in the community, deprescribe medications, ordering DME, which I know is a huge headache for a lot of primary care providers, and another side talk that we developed during the grant period that we're happy to share. Referring to ophtho, treating vitamin D, and screening and treating for osteoporosis. And then again, just some other interventions, again, vitamin D, exercise programs, reducing meds, improving the environmental risk as well. So home safety evaluations, referring to PTOT, and then treating those medical risk factors, including visual impairments like cataracts. All right, so the next step is medications. And this really, my takeaway for all of you is really doing good, thorough med reconciliations is incredibly valuable, and spending that time to really assess what patients are taking and assess their understanding and adherence to those medications, and again, really deprescribing as much as possible and as tolerated. But yes, a lot of our patients have polypharmacy because they need all of those medications, but also targeting those potentially inappropriate medications for the older adult population. So the benzodiazepines, opioids, anticholinergics, muscle relaxants, tricyclics, and antipsychotics, as much as possible, making sure we know the reasons for those prescriptions, and as much as possible, reducing those, because of the side effects for this population are so significant. So what do we do? Again, deprescribe. If an older adult takes one or more of the medications listed, discuss concerns the patient may have, assess for adverse effects, and discuss deprescribing. Some resources. So I think that one of the things I'll talk about later is the importance of teams in this work. I know most IFH sites do not have a pharmacist. I think that is an incredibly valuable resource when available. Also thinking about your local community pharmacists and the role they may have in caring for your older adults, and communicating, coordinating with them is very important. Also thinking about using your nurses, your team members to do med reconciliation and education as much as possible. And again, those community pharmacists who can provide services like blister packages, I'm a huge supporter of those services, and help set a lot of people up on those. It takes some time and effort, but really a huge intervention that can be quite helpful. And of course, thinking about non-pharmacological approaches when possible. And then as an institution, thinking about targeting some of these high-risk medications, looking at data and reports. During the grant period, we also got some pill boxes, some single layer ones and some double layer ones. We distributed them to the nurses, nursing leadership at many of the New York City sites. So if you want to know where they are, ask your nursing leadership. At Harlem, there are some in the preceptor room on the 3rd floor if you want to check out those.
And so for this patient that I was speaking about, as I referenced already, we did try to do some deprescribing. There were also periods during these transitions of care from hospital to subacute rehab back to the community where there were changes in her medications. And then, unfortunately, in the last few visits, it's become obvious that her family has been less available to support her. So the daughter who was managing a lot of her medications is now unable to. And so the last few visits, I really have been working on setting her up with blister packages and helping her manage her medications, hopefully in a safely way. Some other resources, I know many of you know about the Beers list, having access to that and being aware of medications on that list. There's also a really cool website called deprescribing.org that I haven't been using as much, but every time I go on there, I'm always surprised by what cool information is on there. Some algorithms for deprescribing, including deprescribing benzos, PPIs, et cetera. So that's a cool resource to take a look at. And then lastly, what matters most. This is really, again, just documenting what's important to a patient. A quick plug to our EPIC team, there is a advanced care planning tab. There is a tip sheet that shows you how to use this tab. Not only can you scan your important documents, but there's also opportunity to document an advanced care planning note. So even if you don't create a document, if you talk to a patient about their values, what's important to them, their prior experience with family members who had advanced illness, you can document that in an ACP note, and that can be more easily found versus if it's embedded in your regular notes. But yeah, in terms of what we do in primary care, getting good social histories and doing a social assessment. For our patient, she was born in the DR. She only, like I said, she only had a few months of schooling. She worked herself as a home attendant and retired in 2003. She'd been widowed since 1992. She has 4 living children, many not involved in her care, one who was in the DR. And she lives alone. When I met her, she had 6 hours Monday through Friday. She now has 8 hours a day, 9 to 5. And it's still a continuous fight to try to get more home care hours. But really knowing more about that home environment, what's going on, who's available, who are the resources, the support for our patients is super important. And continuing to assess for also substance abuse and sexual activity is also something that we don't think about as much in this population, but important as well. So how to act on this, identifying the healthcare proxy, identifying those goals, documenting them in the appropriate way. A few other resources, if you're interested in learning more, prepareforyourcare.org is a really great website that has some nice patient materials to help you talk through advanced care planning. And also this patient priorities care, which is really a structured way of thinking about how to ask what's important and what a patient's priorities are and helping you align those priorities with your care plan. So our case, she has, in terms of mine, I'm just going to summarize for you. She had known dementia. She was on rivastigmine. I titrated her off her meds due to lack of efficacy. We did some testing. We treated her depression. In terms of mobility, probably one of her highest risks. She is quite dependent now on her all of her IADLs and some of her ADLs. Again, multiple falls, many at night when she's alone. We're continuing to do home physical therapy when possible, getting equipment and that she needs. And really that increase in home care hours is something that we're still trying to push on. Good geriatric social workers are also hard to find, but I think a huge resource when available can be quite helpful when we're navigating the Medicaid system. Medications, we've done some deprescribing for her. We deprescribed the pantoprazole, rivastigmine, metformin, Januvia. For example, we're also trying to work with the pharmacy to get her medications blister packaged since her daughter is no longer available. And then matters most. So like I said, we talked about her proxy, her goals. She wanted to be full code because of her prior experience. And that's something I'll continue to evaluate over time as her medical case progresses. Her family member at one point was her home attendant through the CD Pass program, but now she actually has, in the last few visits, been coming with an agency home attendant. So that's something else to be aware of. So just a few other quick plugs before I wrap up. The Medicare wellness visit really, again, has a lot of these components of the 4 M's, and I hope it's something that you recognize is an important tool and a nice way to sort of look into some of these M's. Even if you don't get to a treatment plan or a good assessment and your AWV, saving time at a future visit to sort of get into those things is sort of what I was trying to highlight with that case. This is something from the grant we also created was these postcards for patients. So they're also aware that the AWV will be time to help assess the 4 M's. And those were also distributed to the New York City sites. And then one other big plug for the EPIC snapshot. So special thanks to Dr. Nozel and the PMT team, particularly Becky, who helped us create the snapshot tool in 2020. And so I just want to show you how to find it and to use it. For those of you who hopefully have snapshots sort of early on in your EPIC view, but there is the Care for Older Adults snapshot that is available to you. You can add it as a favorite, so you can toggle quickly to it. And what is it? It is, well, one is it has a tip sheet at the top, which we created with a reminder of what the M's are and some links to resources and more education. But this is what it looks like. This is the mind section, and you can see it pulls in mood and the cognitive assessment for that patient and when the last time it was done and the results. And likewise, the fall screening, the functional status, the healthcare proxy, advanced care planning tabs, those are all visible on this one page. And so when you're precepting residents, bring it up. It's great for chart review when you're seeing your own patients. So I highly recommend one, finding it, and using it for education and also for patient care. And then you can also refer to me in EPIC. My friends at Harlem know how to schedule into my schedule. I see patients on Tuesday mornings. If it's still allowed, I'm happy to do telehealth consults for patients outside of Harlem. I have had some experience with doing telehealth with older adults, which again is a whole other conversation, but I'm happy to be available. Many of you do send me staff messages. I'm not always so prompt in responding, but I'm happy to field questions there as well. And then really quickly, future directions. You know, we need time to do this work. I'm going to use my small opportunity for my soapbox to talk about time, and if we can't get time in our regular days, thinking about how to identify these patients and thinking about different models where we do have the time. So for example, at our geriatrics practice, we have a high-risk group who takes care of these really super complex older adults, and they have the time to do so outside of the hustle and bustle of a regular primary care template. I think it's really important to train teams, our case management teams, our nursing teams. That's what I loved about the grant, was the opportunity to provide some of this education to our team members. I'd love to see more clinic and residency champions who are passionate about this work, and I'd love to collaborate with anyone who wants to work on any of these areas. I know we have a new accountable care organization, collaborating with them. And then the dream is to really even work more with our mental health colleagues, community-based organizations, and home care organizations. And I just show you these last slides because the age-friendly health system is just one small piece of this bigger age-friendly movement. There are people working in city planning and public health who are thinking about age-friendly cities and public health systems, and really thinking about how all of this can help our older adults in the community that we are just going to continue to see as we go on. So age-friendly health systems, really important to know about these 4 M's, and essential to think about how to incorporate them into your practice. And I just want to thank you again to IFH for allowing me to be in your organization for the last 10 years. And these are my daughters with my 90-year-old grandma. So if we have time for questions, I'm happy to take them.
Thank you, Dr. Rivera. Yes, we do have some questions, so I can just read them out to you.
Okay.
So the first question is, how do you refer for home physical therapy?
So great question. I often will, so there's 2 Medicare payments. You can use a Medicare Part A for a certified home health agency encounter. In New York City, we often use VNS, but there are other CHA organizations that we often refer to, especially if insurance is not parring with VNS. But I'll often refer for a CHA, certified home health agency. I don't know if the question is literally how I do it, but I personally do fill out the referral form from VNS myself and fax it over. But I do think you can use care management for that as well. And then there are a few community physical therapists who bill for Medicare Part B PT, but they do it at the home. So some common ones in New York City are Fox and Outreach Rehab. So those are also available. You can also find their referral process on their websites.
Great. And then the next question is there any data about our Mid-Hudson sites to share? They have a large portion of Medicare ACO patients.
Yeah, I'm sorry I didn't prepare that, and I'm sure we could try to get that, but I have heard that from others in the leadership that you do see a large amount of older adults there. So I'm sorry I don't have that information.
Okay, and then next question is, what is the evidence that vitamin D supplementation affects outcomes?
Yes, so that is a hot topic of debate as well. I think the main reason that we think about it is that vitamin D receptors are in the muscle bodies. And so there have been some evidence that vitamin D can help reduce falls because of that. So in general, my practice is to just give everyone 2,000 units IUs a day, especially for older adults who often don't go outside in New York City, for both repletion and then maintenance is sort of my general practice. But yes, it's a hot topic with lots of data out there. And then I see the substance abuse question also from Dr. Lurio. Yes, it is. I don't have the data, but it is definitely something that we're still seeing. And I think I alluded to it later, that is something we need to continue to assess. When I actually gave my job talk at Sinai on heroin addiction in older adults. So I have some of that information. When I was in San Francisco, I was a little bit more closely connected to some of that data, but yes, alcohol and other, we're seeing a lot of opioid addiction issues in this population, as well as other substance use. So I don't have the data, but definitely is something we're still seeing and something we cannot forget about screening.
Okay, and then do you have time to take a few more questions?
I do, if there is. Let me see if I can quickly say, how do I approach the conversation? They may not be safe at home anymore, and long-term might be the, so this is long-term care might not be the best option. So this is super tricky. There are patients who feel very strongly about remaining home. And as much as possible, I try to support that if that's their goals and their wishes and the family's goals and wishes. So it's really like putting into place as much as we can. But ultimately, at the end of the day, if someone does need long-term care, explaining to them what that means and family members. But there are a lot of people that out there that I think should be in long-term care and are not. And unfortunately, it's sometimes waiting for a bad incident or outcome to happen, which ultimately results in hospitalization and then potentially placement from there. But it's really hard. It's a super, super difficult situation. I don't have a magic answer. I see red is on. Do you want me to stop?
No, Veronica, keep going. I mean, this
Okay.
is,
Vaccines, I think there's, yes, challenging in 15 minutes. I agree. And even over 5 to 6, telehealth. And I agree with whoever wrote all of this, that absolutely is challenging. I'm always running late in my practice. But I kind of what I alluded to is really thinking creatively of how do we sort of, can we identify these really high risk, especially as there's such a huge movement to move to value-based care? Can we think outside of the traditional fee-for-service model and think about how can we care for these really high complex, high utilizing patients, to really separate them out and think about other ways to care for them and outside of the traditional 15-minute visit. I 100% agree, and important to think about. In terms of home safety assessment, also I refer for home PT. And then can we get an easy way, run and review, report patients with potentially inappropriate meds? I'm sure there must be a way in Epic to run a report. I have not personally done a report myself on those, but we can look into that and get back to you. Although I don't know who wrote that, sorry. I think that's everything in the chat.
Okay, great. Thank you so much. So everyone, the survey link is in the chat, and let's see if we can go ahead, and it should be on your screen.
yeah.
Oh, sorry.
No, I was, this presentation feels like a geriatric visit because there's so much information and we only have an hour, and which means that we need to bring you back. And just you've given us so many great ideas, and we will get the data on our Mid-Hudson practices. In fact, because they have a larger Medicare population than the city as well, so that was just an oversight on our part. But thank you. This has been great, and again, we will have you back. And thanks again. The personal stories were just perfect. It's just to remind people, this is a relationship-based practice, and I think you highlighted that. So,
Thank you. Thanks again, everybody. Appreciate it.
Have a good weekend. Take care.
Thanks. Bye-bye.
Bye-bye.
Thank you, Dr. Rivera.